I'm Ann Greiner, President and CEO of the Primary Care Collaborative, and I want to welcome you to today's webinar. If those of you do not know the Primary Care Collaborative or the PCC, we're a national organization that convenes stakeholders from across the healthcare landscape to improve the nation's health by strengthening primary care. And today we're going to have a conversation about a new model for strengthening primary care that will reform payment and delivery. And we'll be kicking off this webinar with an exciting guest, Dr. Liz Fowler, Director of the CMS Innovation Center, who will give a short presentation, and then I'll follow up with a Q&A with Liz. From there, Ben Money, Senior Vice President, Population Health at the National Association of Community Health Centers, or NAC, will deliver some short remarks. And then we'll transition to a discussion on what Liz announces, featuring Sean Martin from the American Academy of Family Physicians and on PCC's Board of Directors, Aisha Pittman from the National Association of ACOs, and Sarah Combs from the National Partnership for Women and Families. So let me welcome Liz. She is the Deputy Administrator and Director of the CMS Innovation Center, which I mentioned earlier, and Dr. Fowler was previously EVP of Programs at the Commonwealth Fund and Vice President for Global Health Policy at Johnson & Johnson. Prior to that, she was Special Assistant to President Obama on Healthcare and Economic Policy at the National Economic Council. And before that, she was on Capitol Hill. She was Chief Health Counsel to the Senate Finance Committee Chair, Senator Max Baucus, where she worked on the Affordable Care Act. Let me turn the baton over to Liz, and you can tell us the exciting news out of CMS CMMI this morning.
Great. Thank you so much, Ann, and thanks to the Primary Care Collaborative for hosting this webinar. I also want to thank our partners at AAFP, NACOs, NAC, and the National Partnership for joining today as well. I really appreciate this opportunity to talk about the CMS Innovation Center's strategy to promote and support primary care, and the newest model we just announced this morning, the ACO Primary Care Flex Model, or ACO PC Flex, as we're calling it. I think most of your viewers know that the role of the Innovation Center is to test new payment and care delivery models that have the potential to improve quality for Medicare and Medicaid beneficiaries while holding or even lowering program spending. We're essentially the R&D component of CMS. Our models focus on specific conditions or disease like end-stage renal disease, cancer, and dementia, specific healthcare providers like primary care practitioners, state-specific models like the Maryland Total Cost of Care model, and then we also test models in Medicare Advantage and Part D prescription drug plans. In 2021, we laid out a strategy that focused on 5 strategic objectives in furtherance of the center's vision, a healthcare system that achieves equitable outcomes through high-quality, affordable, person-centered care. Those objectives, and I'll just go through them shortly before I get to the main punchline of the conversation. First, drive accountable care that promotes delivery of whole-person integrated care. We want beneficiaries in traditional Medicare to have integrated, coordinated care and patient navigation that leads to better outcomes and improved quality. And we set an ambitious goal for all Medicare beneficiaries and the vast majority of Medicaid beneficiaries to be in a relationship with a provider who is accountable for total cost of care and quality by 2030. And primary care is the foundation of this objective. And of course, we'll speak about that more in a moment. Second is advancing health equity, which is really critical to improving healthcare quality. This is a priority for CMS and is one of Administrator Brooks Schure's strategic pillars for CMS as well. Third, supporting innovation that enables the delivery of person-centered integrated care. What more can we do to help model participants be successful in terms of tools, data, resources, and regulatory flexibilities? Fourth, affordability by addressing healthcare prices and reducing duplicative or unnecessary care, in part through access to high-value care, such as primary care and preventive care, and referrals to high-quality specialty care. And then finally, we need to partner to truly achieve health system transformation. That means working more closely with our other payers, as well as with providers and patients. The Innovation Center has a role to play in supporting primary care to drive a better health system that works for patients. And as I said, primary care is the cornerstone of a lot of our goals to achieving broader health system transformation. We know that access to primary care is associated with better outcomes, lower mortality, higher life expectancy, and health equity at similar or lower total costs. Integrated team-based care is really central to bending the healthcare cost curve and driving better outcomes. Last summer, we outlined a strategy to support high-quality primary care with 3 pillars. The first of those pillars is improving primary care financing through increased stable revenue that moves practices away from fee-for-service payments and toward prospective payments that better support team-based coordinated care and care coordination with specialty providers, as well as community-based supports. Second, advancing health equity by increasing participation by safety net providers in value-based care, increasing payments to underserved areas and requiring health equity plans from model participants. And then finally, supporting the sustainability of value-based payment models by creating pathways for scaling successful features and models into the Medicare program and through multi-payer alignment. Tying all of this together, the Innovation Center has applied features from each of these dimensions to 2 of our primary care models announced last year, or related, our 4th generation primary care model, Making Care Primary, and then the AHEAD model, which aims to amplify Medicaid-led advanced primary care efforts by aligning Medicare fee-for-service and other payers. But we need a multi-pronged approach to meet primary care practices where they are. And that's where ACO PC Flex model comes in. In this model, we're giving primary care providers and ACOs a new pathway to join and succeed in value-based care. The ACO PC Flex model is a voluntary payment model within the Medicare Shared Savings Program. New and renewing low-revenue ACOs that participate in the Medicare Shared Savings Program are eligible to apply to the ACO PC Flex model. ACOs will jointly participate in the Shared Savings Program and the ACO PC Flex model. The model tests how improved payments for primary care impacts health outcomes, quality, and costs. It's designed to empower participating ACOs and their primary care providers to use more innovative, team-based, person-centered, and proactive approaches to care. ACO PC Flex builds on payment policies tested in our previous ACO models and will provide 2 new payment mechanisms for ACOs in the Shared Savings Program. First is a one-time advanced shared savings payment, which can be used to cover costs associated with forming an ACO, where relevant, in addition to administrative costs for implementing the model's required activities. And then second, a monthly prospective primary care payment, PPCP, which will shift payment for primary care away from fee-for-service visit-based payment and increase the predictability of primary care funding for low-revenue ACOs. We know that more predictable cash flows can offer more flexibility and stronger incentives for primary healthcare providers to work together to coordinate care and meet the needs of people with Medicare. In contrast to previously tested CMS Innovation Center models, the rate for the prospective primary care payment is not based on historical spending estimates. Instead, it's based on a county's average primary care spending before social and clinical risk factors are applied. This county-based payment will help reduce entrenched disparities in primary care investment and utilization by giving all beneficiaries in a county access to the same level of care, regardless of which ACO serves them in a county. The model includes specific policies designed to ensure funds flow to an ACO's primary care providers and are used to support primary care as intended. It strengthens shared savings program participation incentives for new low-revenue ACOs, particularly those that will support underserved communities, and aims to reduce disparities in health outcomes and access to primary care. Low-revenue ACOs tend to be mainly made up of physicians and might include a small hospital or serve rural areas. New and renewing ACOs need to apply for the Shared Savings Program before applying to ACO PC Flex. Currently participating ACOs may apply as a renewal applicant and begin a new agreement period. ACOs will be asked to indicate their interest in the model within the Shared Savings Program application. The Shared Savings Program application period opens on May 20th this year and closes on June 17th. You can visit the Shared Savings Program's application types and timelines webpage for more information. This model is a really important step toward achieving the CMS accountable care goal. And further, a test within the shared savings program will support CMS's ability to scale successful features of the ACO PC Flex model in the future. I want to turn back to Anne and just again personally thank PCC and their members and the other organizations joined on this call for all of their efforts to help shape the model. So turning it back over to you, Anne.
Well, thank you so much, Liz. Very exciting news out of CMS this morning, and really appreciate your remarks. And we're very, very grateful to you all and your team for the way you've really moved forward very quickly to set out models to improve access, expand access, and you're taking some very important steps to strengthen primary care, because we all know that that's the pathway to improved health outcomes, better equity, and yes, even eventually reducing costs. And we really do appreciate the work that your team has done over the last year with us, with many primary care clinical groups, with NACOs, gathering input from all of us to inform your thinking. In addition to a lot of other input from thought leaders. So, we first brought this concept with more than 24 different stakeholder groups just about a year ago, less than a year ago, actually, to you all. Can you describe a little bit about how the team moved this forward to get to where we are today and what was involved?
Well, thanks for that question. And honestly, and I've said this before, we really could not have developed this model without the partnership of the PCC and the organizations on today's call. We have really appreciated the information you shared through multiple listening sessions and patients with patients and consumers, primary care clinicians, ACOs, and policy experts. Your insights were incredibly valuable, and because it was such a focused amount of effort, it really enabled us to really hone in on what we needed to do in the model very quickly, maybe more so than other models, and so we were able to move much faster than we usually do.
I think we always like to think about first, how will new models make care better, different for beneficiaries? Can you describe a little bit about what you believe will happen under this model for Medicare beneficiaries?
Well, as you and I both just said, we know based on evidence and experience that people who have access to high quality primary care are more likely to receive preventive health services and screenings, to experience improved health outcomes related to mortality, disease progression, and chronic care management. ACO PC Flex aims to increase access to high quality primary care for people with Medicare by improving funding and other resources to enhance primary care in ACOs. And this flexible payment design will empower participating ACOs and their primary care providers to use more innovative, team-based, person-centered, and proactive approaches to care, which we think will translate to better care for patients. The model is also based, in addition to a lot of input from you and others, as I mentioned, is based on recommendations made by the National Academies of Sciences, Engineering, and Medicine in a report entitled Implementing High-Quality Primary Care, Rebuilding the Foundation of Healthcare, which recommended that funds flow to primary care through ACOs to better support that team-based care and provider infrastructure that we know will improve care for patients.
Well, I'm really glad you mentioned that report, because it's a bit of a Bible for us, given all the evidence that the National Academy of Science, Engineering, and Medicine brought to its recommendations. And this notion of hybrid payment, a mix of fee-for-service and a prospective payment, to balance out the different incentives in a payment model. Potentially also getting more organizations on the value-based payment train, if you will. And so we're very excited about this new model. How do you think it will benefit clinicians?
Yeah, well, first, let me just say the NASM report has been a Bible for us as well, and it has guided a lot of our work. It was really foundational. And so really want to thank that organization and all of the participants in that report. ACOs and their primary care providers have been limited in their ability to provide advanced primary care because of visit-based payment mechanisms and financial incentives in both fee-for-service Medicare and in the shared savings program. ACO PC Flex will strengthen incentives for primary care providers to form ACOs, including providers caring for underserved beneficiaries. It will test enhanced and prospective primary care payments to enable more team-based care, as I mentioned before. And in my remarks, I included a description of both of these payments. And just to reiterate them again, there's the monthly prospective primary care payment, which will shift payment from primary care away from fee-for-service visit-based payments, and will increase predictability of primary care funding. And then that one-time advanced shared savings payment, which can be used to cover costs associated with forming an ACO and the administrative costs for required model activities. So we think there will be a number of ways that this will benefit primary care providers, and look forward to rolling it out and watching it work.
Well, thanks so much. And I think we've heard often from primary care clinicians that if they have a sufficient amount of resources and they are predictable, then they're going to feel more comfortable building out a team to provide a more comprehensive set of services, which I think they want to do. And I think, it's really what patients want. So it's exciting to think about where this could go. You also mentioned in your remarks the real importance that this administration places on health equity. You really center health equity in your work. Can you tell me a little bit more about how the ACO primary care flex model will attract and support rural health clinics and federally qualified health centers?
Yeah, thanks for that question. It's a really important one for us. Growing participation by safety net providers is really a key factor in improving access to care for underserved populations, including those in rural areas and historically disadvantaged communities. ACO PC Flex includes special considerations for RHCs and FQHCs who are not paid fee-for-service like other primary care providers. A beneficiary level adjustment to the prospective primary care payment, or PPCP, is included for beneficiaries who receive the plurality of primary care services based on allowable charges at FQHCs and RHCs. And because of the all-inclusive payment rate is different for FQHCs and RHCs, there will be a different primary care per beneficiary per month adjustment amount for each of these settings to encourage FQHCs and RHCs to participate. And we know we'll need to do a lot to do some outreach and work with our provider community. And that's why I'm really glad to see Ben Money and NAC on the phone to help get this message across.
Super. Well, we're also very excited to be working across all different kinds of primary care practices in a model. And I think we can, learn from each other and move forward together because of that kind of interaction. Liz, is there anything else that you want to add as we wind up our conversation here and transition to remarks from Ben Money and NAC?
Well, I think maybe the last thing I'll say is I hope that the public and providers and participants in our models and our healthcare system generally is getting a sense of a larger picture that we're trying to paint, which really does include foundationally improving primary care. As we've been rolling out and announcing a number of models over the past year, I hope folks are starting to see the pattern and how they all fit together and relate to each other, and how there really will be multiple opportunities for providers at all levels to join value-based care and to be successful in value-based care. And that's really what we're aiming for, and really appreciate your support again. And thank you for hosting this webinar.
Absolutely. And it's clear what your commitment is, and also that you recognize that primary care there's so many distinct models. They're taking care of different populations. They've got different geographic realities. And I think having an array of ways that primary care can participate in value-based payment is so important. So thank you so much for your remarks today and for the work of the team. We're thrilled to have this conversation.
Thank you, Anne.
Now let me welcome Ben Money. He is the Senior Vice President for Population Health at the National Association of Community Health Centers. And he, in that role, serves as the executive lead for value-based care, care transformation, social drivers of health, and environmental health. Ben's 40-plus year career, I can't believe that, Ben, includes serving as the president and CEO of the North Carolina Community Health Center Association. And he also was appointed as the Deputy Secretary for Health Services at the North Carolina Department of Health and Human Services. So he really brings an incredibly rich background to his current position. For those of you who may not know, CHCs provide care to 1 in 11 Americans, many who come from the nation's rural and underserved communities. Ben, over to you.
Thank you, Ann, for hosting this webinar and inviting me to share comments today. I'd like to also thank Dr. Fowler and the CMMI team for designing the ACO primary care flex model with the needs of primary care providers and particularly community health centers in mind. Federally qualified health centers are patient-governed organizations serving 31.5 million people through 1,400 organizations operating 15,000 clinical delivery sites across the U.S. and its territories. Their services are available to anyone, regardless of ability to pay. Over 90% of health center patients live below 200% of federal poverty level, and patients aged 65 and older are our fastest growing population. It's through increased investments in primary care that America will improve health outcomes, close disparities, and reduce overall costs. Moving from fee-for-service to value-based care is essential for providers to focus on patients achieving good health rather than simply delivering services. The ACO primary care flex model is a step in that direction. This new model includes special considerations for FQHCs and RHCs' unique payment methodology and the need for sufficient stable revenue to support the transition from fee-for-service to value-based care. ACO PC Flex will enable increasing access to care that is equity-focused and patient-centered. During my tenure as Primary Care Association Director in North Carolina, I learned firsthand the power of health centers teaming up as an ACO to enter an MSSP contract. The ACO PC Flex model is a promising approach to leveraging the power of the health center model at a larger scale at an ACO scale. Currently, there are over 40 states where health centers are participating in the journey towards value-based care through clinically integrated networks. The ACO PC Flex model incorporates a one-time advanced shared savings payment that can support ACO foundational infrastructure necessary for success in value-based care, such as analytics and care management. ACO Flex will also provide monthly prospective primary care payments that will enable primary care practices within ACOs to use team-based, person-centered care and deploy innovative delivery approaches. Importantly, ACO PC Flex includes policies specifically designed to ensure that prospective primary care payments made to the ACO flow to the ACO's primary care providers and are used to support primary care. I applaud CMMI for focusing on equity, access, and primary care. You've kept an open door along the way. You've welcomed our input as thought partners in your model development. The ACO Primary Care Flex model represents an exciting opportunity for health centers and their networks to advance along the value-based care continuum. Thank you.
Thank you so much, Ben. And exciting to hear that you've got innovation going on in 40 states across the country. That's wonderful. And through your work and your new CEO, Dr. Q. Ree, we know that's just going to accelerate further. So really appreciate it. Now let me welcome our panel, who's going to reflect on the model as laid out by Liz Fowler and also on Ben Money's remarks. First, I'd like to welcome Sean Martin. He's Executive Vice President and Chief Executive Officer for the American Academy of Family Physicians, and they represent over 130,000 family physicians and medical students. As mentioned earlier, Sean is a member of the Primary Care Collaborative's board and one of 4 primary care physician organizations that helped start the PCC. He served on many different boards, including NCQA's Patient-Centered Medical Home Advisory Board, ARC's Practice Transformation Advisory Board, the Hospital and Facilities Accreditation Program Patient-Centered Medical Home Advisory Board, and others. And I'm thrilled that he's with us today. Aisha Pittman is Senior Vice President of Government Affairs for the National Association of ACOs. She has 19 years of experience in healthcare payment, alternative payment models, healthcare quality measurement, and healthcare information technology. Aisha was previously VP of Policy with Premier, a group purchasing organization of more than 4,400 hospitals and 225 other provider organizations. We also work together at NQF. Sarah Combs, Director for Health System Transformation at the National Partnership for Women and Families, where she manages policy and programmatic work on health access and system transformation. Sarah's also one of the co-chairs of the Primary Care Collaborative's Policy and Advocacy Group, along with Sherry Erickson from ACP. Prior to her work at the National Partnership, Sarah worked at the Office of the Secretary of the Department of Health and Human Services, where she contributed to policy development and implementation of the Affordable Care Act and delivery system transformation initiatives. Thank you all very, very much for being here today. Let's start with you, Sarah. We want to really think about how we consider these models with the patient in mind. Really, we've got to center the patient. So perhaps you could think about a typical patient in Medicare, maybe a 75-year-old woman or some other person that you might have in mind. What could this model mean for that person?
Thank you, Anne, and thank you for having me on this call. Well, I'm so glad that you raised the point about who matters most in high quality primary care, and I think too often we get bogged down talking about payment mechanisms, and I think it's so important to highlight what it all means for patients and families, particularly those who experience the most inequitable outcomes. So I'd like to think about a 7-year-old Black woman who lives in an underserved community and has complex health and social needs. I appreciate what Liz highlighted earlier, that this model does not factor in historical spending and applies social risk factors to help bring greater resources to communities who need them most. And I think this really differs from fee-for-service models that often reinforce patterns of underutilization among systemically underserved communities. So this model could really potentially help address some of the longstanding inequities in healthcare access and outcomes, like those in underserved communities where this potentially 7-year-old woman lives. And they stand to really potentially benefit the most from models like this one. But beyond the specifics of the payment mechanism, I think it's just really important to drill down what it could potentially mean for her care delivery and outcomes. And what we know so far about this model is that this 75-year-old woman could potentially have greater access to advanced primary care, which at its core is about continuous relationship-based whole person care. Specifically, her care experience could significantly improve by receiving improved care management for her chronic conditions, better care coordination, having greater use of email and phone communication with her care team, who are also, able to effectively communicate with her other care providers and social service providers in her community. She may also even have greater access to various forms of telehealth that enable her to receive support at home. Finally, she could potentially have greater access, or she might actually have access to a multidisciplinary team-based care team that is so critical to enable to be able to address just her multiple physical, behavioral health, and social needs that she has. The two final points I just really want to make, and I know that we're short on time, is on cost sharing support and integrated behavioral health. I think we all know that affordability is a top concern for most families. And I think that we understand that there are statutory limitations within MSSP to kind of defray cost sharing for some patients and not for all. But in an ideal world, this model would also have those waivers that allow ACOs to offer cost sharing support to help with copays, much like we see in ACO REACH. And on the behavioral health point, I think it's just really encouraging to see all the efforts that are made, that have been made at CMS in support of integrated behavioral health, much like the new behavioral health model. But I do think overall there's definitely more room for improvement. For one, I think we all need to have like a shared definition of what behavioral health integration actually is in the context of primary care payment. It could look like screening or referral, or all the way to having a frontline behavioral health clinician in the practice that's able to like have prescribing capabilities. So in the context of like what this could look like in this model, I think it's just important to consider like having like a tiered payment approach and accountability to ensure that there's actually enough resources to support meaningful behavioral health integration, and to make sure that those resources are actually going to those services. But I'll just stop there. I think overall we're really excited about this model. We have been in partnership with you all and NACOS and others to really move this ahead. So it's really exciting to see this, and I'll pause. Thank you.
Well, thanks, Sarah. And what you described sounds absolutely wonderful. And for those of us who have elderly parents, if they had access to these kinds of services, we know that it would be a game changer, and appreciate your reflections, and also continuing to push on what we hope will be a continued evolution of these models. Sean, the AAFP, Millbank, the PCC, and many other organizations have partnered in recent years to really highlight the underinvestment in primary care. The latest data shows that it's 4.7% of our healthcare dollars. So less than 5 cents goes to primary care, and this has consequences for access and for the workforce. How do you think this new model might actually get more dollars to family medicine and other primary care practices across the country? And what do you think primary care practices might choose to do with these additional resources?
Yeah, well, thank you so much, Anne. I also appreciate the opportunity to be here today, and let me just congratulate Dr. Fowler and her team. I think this is just tremendous work, a tremendous acknowledgement of where progress has been made, and a really thorough analysis of data and opportunity, and there's a lot to learn still, and look forward to engaging on that learning, but really happy with the words that are on paper and kind of where this program is heading. So your question is a good one, and I think obviously there are limitations in the total amount of dollars that can be shifted within the Medicare program, but as we all know, there's different ways that you can deploy those dollars, and I think what they have accomplished in this model is to take a prospective or capitated view of giving practices kind of capital, if you will, so that they can begin to adjust how they approach care delivery and how they approach their assigned patient population, versus asking them to continue to do that on an episodic or fee-for-service type basis. So I think the upfront cash flow or financial resources that are being made available in this model is really going to transform the approach to patient care, particularly those patients that have the most need, or maybe have been most neglected or vulnerable in the fee-for-service model. What practices will do, I think first and foremost, you will see them become much more aware of and focused on those patients that have the most needs in their practice. I mean, we know in the Medicare program, something like 95% of Medicare beneficiaries have one chronic condition, 80% have 2 or more. So it's not hard to start to think about how you stratify and work on identifying high need patients in the practice. But I think the other thing, I would just pick up on what Sarah said. I think one of the things we hear from our members frequently is, I want my practice to be multimodal, and I want my payments to be agnostic to modality. And I think you see programs like this really create an opportunity for practices to focus on the right care at the right time and in the right modality. And sometimes it's a phone call, sometimes it's a home visit, sometimes it's an office visit. But that decision in advanced primary care practice under this financing model rests with the patient and with their primary care physician or primary care team. And I think that's an important transition. And I would just close with this. I mentioned at the top, like using data, to inform decision-making. And I think I really appreciate that they've taken a step to acknowledge that this opportunity for physicians to empower and be successful in the MSSP program is really consistent with what we've learned over time, which is where you see physician leadership in the MSSP program, you tend to see better success or a tendency towards success that's different in those populations. And lots of people are being successful in healthcare innovation and delivery, but I just think really pleased with the evolution that we're seeing today.
Well, thank you so much. Lots of wise words there and a lot of experience. So appreciate that. Finally, Aisha, we've had ACOs since 2012 in the Medicare program. And what do you think this new model of paying primary care might mean for this longstanding program of Medicare?
Thanks, Anne. And I also just want to send a congrats to Dr. Fowler and the entire CMMI team for launching this model. Ultimately, ACO, their foundation is primary care. It is how beneficiaries come into the model through a relationship with primary care. And what we know from the decade, or more than a decade of learning in this, is that how ACOs reinvest their shared savings goes back to primary care practices, both in terms of just bonus payments directly to the practices, but then also helping the practices build more infrastructure to continue to innovate and change how they deliver care. I think from this decade, we've learned that the shared savings approach is just not enough. It comes 2 years later after the performance period, and we need to really shift to a more upfront approach to help practices reinvest in their patients. And so shifting away from fee-for-service payment to a population-based payment model is the next evolution. And we have a lot of experience from this already. The next generation ACO model had an approach. REACH has a similar approach. And we know, and research has proven that ACOs who were concurrently participating in CPC Plus had better performance than ACOs who were not. So we really think this offers huge opportunity to change the cash flow and also give providers more tools to better innovate care. I think we will see a lot of strong interest from ACOs, but I would be remiss without saying that, a way that we can really drive more ACOs and practices and ACOs into the model would be to expand this to all ACOs. There's a lot of independent primary care practices, FQHCs and RHCs that are partnering with high revenue ACOs that also want similar options. But overall, really pleased to see this model, and we think it's going to be a great opportunity for ACOs to really evolve how they change care. And we think it's really critical that we are putting this innovation on top of the permanent model where we've had so much success.
Thanks so much. And I think that we all want to see this kind of innovation move into the permanent programs as rapidly as possible. And we also, I think, would all agree that Medicare is such an important payer here, because as Medicare goes, often the whole healthcare system does. And I think we would all agree that the best case scenario is for a primary care practice, if they're serving, all ages and all programs, to have alignment. So clearly that's what we want to drive towards. There's so many flaws that result as a consequence of the fee-for-service system, but they hit rural and underserved communities the hardest. I'm curious what you all think about how this model might better serve those communities, and I'm just opening it up to whoever would like to respond. Sean, you look like you're
Yeah,
first.
I think a lot of it is just they call it the flex model, and I mean I think that's a really interesting word because of the flexibility that the model affords practices. And similar to what I said in my previous answer, I think primary care practices, particularly those that are inclined towards a value-based orientation, it's really more about what you take away than what you add, right? Like you want to give them the freedom to approach their assigned patient population in a manner that's best for the team that they have available to them and the patient need. And I think fee-for-service is just very restrictive. It's an auditing system. It's not aligning with kind of primary care values or patient-centered primary care values. So I think the prospective payment or capitated payment model really starts to move payment, to be a little more agnostic towards modality and a little more supportive of really doing what's best for the patient in the moment. And I think oftentimes the Medicare program on the fee-for-service side, influences that disproportionately by how they pay for the moment. And this removes that type of influence.
Super. Anybody else want to jump in? Okay, as we wrap, and I think of the primary care flex in the way that you said, Sean, flex, but I also think of it as primary care flexing, honestly, to help drive our system towards health and wellness. And I think this is what the American public wants. They want to, remain healthy, or if they get sick, get quickly restored to health. So I'm glad to have primary care flexing. Very quickly, if you reflect on the announcement today, how do you think it's going to move things forward? Just very quick popcorn answers. First, go to Sarah.
I just want to just drill down what I said earlier. I think it will provide more access in communities that do not have access to advanced primary care. I think it will really enable ACOs that have been shy to enter the MSSP, the shared savings program, to actually come in. And so it just provides another pathway for other ACOs.
Thanks.
I'll go. I'll say,
Ladies first. Sorry, Sean.
it's going to allow us to see how practices can innovate care differently when they have a stable and predictable cash flow. We haven't had that in this model, and I think when you know upfront what you can do and where you can allocate funds, you invest differently. And so I think we're going to see the next generation of innovation.
You've got the last word.
Yeah, I would just say, look, I think it is a natural evolution to true patient-centeredness. I don't think this gets us all the way there. But I think fee-for-service obviously centers services, and I think this model, moves us more towards centering patients, and I think that's a really good thing.
That's a great way to end. Thank you so much for joining us. Thank you all for tuning in today. April 4th, CMS will have a webinar to answer more of your questions, and we look forward to further conversation. Have a good afternoon. Bye.